Hello dear friends, welcome to PharmaGrid. So let's continue with the remaining KAPS recalls discussion. Beginning with question number 41. Hypocalcemia is not caused by which of the following conditions? The options are hypoparathyroidism, vitamin D deficiency, neoplasm, administration of loop diuretics. So here the correct answer is option C, that is neoplasm. Remaining all other conditions, that is hypoparathyroidism, vitamin D deficiency and administration of loop diuretics, these conditions are all associated with the hypocalcemia. Exception is neoplasm or cancer. Hypercalcemia is associated with malignancy or metastatic diseases. Hypocalcemia usually implies a deficiency in parathyroid hormone or vitamin D. Hypoparathyroidism is a rare condition in which the parathyroid glands fails to produce sufficient amounts of parathyroid hormone, or the parathyroid hormone produced lacks biologic activity. This parathyroid hormone along with vitamin D and the hormone calcitonin. This hormone calcitonin is produced by the thyroid gland. These all together plays a role in regulating the levels of calcium and phosphorus in the blood and in determining bone growth and bone cell activity. The calcitonin is released in case of hypercalcemia. So the function of calcitonin is to decrease calcium levels in the blood, and the parathyroid hormone will be released in case of hypocalcemia because the parathyroid hormone will increase the calcium levels in the blood. So due to a deficiency of parathyroid hormone, individuals may exhibit abnormally low levels of calcium in the blood, that is hypocalcemia, and high levels of phosphorus, that is hyperphosphatemia. So there is always an inverse relationship between calcium and phosphorus. Now about the loop diuretics. Loop diuretics include furosemide, torsemide, etc. They may lead to hypocalcemia by enhancing the renal excretion of calcium. The inhibition of sodium reabsorption in the loop of Henle causes reduced reabsorption of calcium. Question number 42. Which of the following is an adverse effect associated with metformin? The options are lactic acidosis, agranulocytosis, constipation and hypersalivation. So here the correct answer is option A, that is lactic acidosis. Metformin is a biguanide compound used as first-line therapy for the treatment of diabetes mellitus and prevention of diabetic-related microvascular and macrovascular complications. It is also used to treat several other conditions including polycystic ovary syndrome, hyperinsular obesity, and weight gain from antipsychotic therapy. The adverse effects associated with metformin are mainly gastrointestinal, including diarrhea, nausea, and vomiting. Then metallic taste in the mouth. Most serious and rare side effect is lactic acidosis. Then long-term use may be associated with a vitamin B12 deficiency. This lactic acidosis occurs when lactic acid production exceeds lactic acid clearance. The increase in lactate production is usually caused by impaired tissue oxygenation, either from decreased oxygen delivery or a defective mitochondrial oxygen utilization. Next question. A patient has a documented allergy to penicillin. Which of the following antibiotics should not be given to this patient due to the risk of cross-reactivity? The options are ciprofloxacin, which is a fluoroquinolone antibiotic, azithromycin, which is a macrolide antibiotic, cefalexin, which is a first-generation cephalosporin, and doxycycline, which is a tetracycline antibiotic. So here the correct answer is option C, that is cefalexin. That is the cross-reactivity between penicillin and cephalosporin is around 3 to 5%, and the highest rate of cross-reactivity is between penicillin and first-generation cephalosporins. Here in the option, cefalexin is a first-generation cephalosporin and the highest risk of cross-reactivity with the penicillin. So here let's discuss about the classification of cephalosporins. Cephalosporins are mainly categorized into 5 generations. As the generation increases, the gram-negative activity also increases. So the first generation have got broad spectrum of activity and low toxicity. Examples include cefadroxil, cefazolin, cefalexin and cefadrin. Then second generation, intermediate spectrum, extended gram-negative coverage, active against Enterobacter, Proteus vulgaris, Klebsiella and Haemophilus influenza. The agents include cefaclor, cefotaten, cefoxitin, cefprozil, cefuroxime. Cefuroxime is available in both oral and parenteral routes. Then third generation have extended gram-negative coverage, including Pseudomonas aeruginosa, Serratia, Neisseria gonorrhoeae, activity for Staphylococcus aureus, Streptococcus pneumonia, and Enterobacteriaceae. The examples include cefoperazone, cefotaxime, ceftriaxone, ceftazidime, cefdinir, cefixime, cefpodoxime, and cefbutane. Then fourth generation, extended gram-negative coverage, increased activity against streptococci and MRSA. MRSA means methicillin-resistant Staphylococcus aureus. The examples include cefepime and cefpiram. Then fifth generation has extended spectrum against MRSA. The examples include ceftaroline and ceftabipirol. Next question. During ovulation, peak plasma concentrations of which of the following hormones will be reached? The options are luteinizing hormone, follicle stimulating hormone, progesterone. So here the correct answer will be answer C, that is luteinizing hormone and follicle stimulating hormone. That is during the menstrual cycle, levels of follicle stimulating hormone and luteinizing hormone will vary widely. But at the time of ovulation, the concentration of each of these hormones reaches a peak, that is this FSH and LH will be at peak during ovulation. Okay, so coinciding with the release of ovum and the complete development of a mature endometrial wall. Question number 45. What can happen when ciprofloxacin is given together with theophylline? The options are theophylline levels in the blood may increase, leading to potential toxicity. Theophylline levels in the blood may decrease, reducing its effectiveness. Ciprofloxacin may cause an allergic reaction when taken with theophylline. The combination can result in a higher risk of gastrointestinal side effects. We know that the ciprofloxacin is a fluoroquinolone antibiotic and theophylline is a methylxanthine that's mainly used as a bronchodilator. So here the correct answer is option A, that is theophylline levels in the blood may increase, leading to potential toxicity. In one of our previous video, we have discussed about enzyme inducers as well as enzyme inhibitors. What these enzyme inducers will do, they will increase the metabolism of the particular drugs that may result in therapeutic failure. And what about enzyme inhibitors? They will inhibit the metabolism of the drugs. So as a result of this, the therapeutic concentrations of the drug may increase, that can lead to toxicity. So here in this case, ciprofloxacin is an enzyme inhibitor. It inhibits CYP1A2 and CYP3A4 mediated metabolism. So as a result of this, it inhibits the metabolism of theophylline, and as a result of this, the theophylline levels in the blood may increase, leading to potential toxicity. Serum concentrations of medications such as theophylline, warfarin, caffeine, sildenafil and zolpidem may be increased. Okay, so with this question, we will wind up today's session. If you like this contents of the video, please share this to your friends also. Thank you for watching this video. Have a good day. Let's see you in the next video.